main inverter for the ankle is the tibialis posterior. The origin of the tibialis posterior is the proximal posterior shaft of the tibia and fibula and interosseous membrane, and the muscle and tendon pass posteriorly to the medial malleolus through the tarsal tunnel and spreads out, attaching to the plantar aspect of all tarsal bones except the talus and the bases of the 2nd through 4th metatarsals. Line of pull for the tibialis posterior will cause both plantar flexion and inversion. The main everters of the ankle are the peroneus longus and the peroneus brevis. The peroneus longus originates from the head of the fibula and proximal 2/3 of lateral fibula and runs posterior to the lateral malleolus, inserting on the plantar base of the 1st metatarsal and medial cuneiform, crossing under the foot. The peroneus brevis originates from the distal 2/3 lateral fibula, also running posterior to the lateral malleolus, and inserting on the tuberosity of the 5th metatarsal. The peroneus longus and brevis both evert and plantar flex the ankle. These muscles are important because they give stability to the lateral ankle. They can help give ankle stability to patients who experience inversion ankle sprains. As plantar flexors, they counteract the inversion tendency of the other larger ankle plantar flexors, such as the gastrocnemius and soleus. Okay, for low intensity exercises for everters and inverters, you'll have your patient seated on a table with the foot slightly off, and she will actively evert and invert her foot. Just like that. This places the everters and inverters in a gravity eliminated position and should be easy for any patients to do, even with acute injuries. Another low intensity exercise for eversion and inversion is having the patient seated on a wobble board. So the patient's seated with her foot flat on the wobble board. You want all the motion to be in the frontal plane, so side to side. You want her going to end range, touching the sides of the wobble board to the ground, and keeping her knee still throughout the exercise. Excellent.
For moderate intensity, the patient can perform resistive TheraBand eversion and inversion. This exercise requires a concentric contraction of the everters, immediately followed by an eccentric contraction of the everters as the patient resists the TheraBand back into inversion. This exercise can be reversed for training of the inverters. These exercises can be progressed by increasing the resistance of the band. Excellent.
Another moderate intensity eversion and inversion exercise is a single leg stance on a firm surface. The patient should stand on the affected leg and keep the knee straight throughout the exercise. This causes more activation of the inverters and everters versus the intrinsic foot muscles. This exercise begins to work on neuromuscular control of the inverters and everters. You can make this exercise harder for your patient by having them stand on a foam surface. A high-intensity exercise for the inverters and everters is a single leg stance on a balance board. Preferably, we would have a balance board that only allows motion in one direction, in this case, the frontal plane, or medial and lateral motion. At our disposal, we have a multi-directional wobble board, so the patient needs external support to maintain frontal plane movement. The patient should try and maintain balance in the middle of the board, not allowing the outside edges of the board to contact the ground. This activates the inverters and everters to maintain this position.
Our final progression for the inverters and everters is called a super skater. The patient will leap laterally off one foot and catch themselves with a single leg, bending the knee as they land. The patient will then push off to leap back to the initial leg. This exercise is a dynamic exercise and activates several muscle groups. However, during the landing phase, the everters work eccentrically to limit lateral motion, and the inverters will assist in the push-off phase.